Is this live? Kindly comment. Are you able to see me? Okay. I think you all can see me. Type I if you can see me and hear me. All good? Okay. All good. I think all is good. I'll start. Okay, great. This is Dr. Shivaam. So most of you have known me, and for those who don't know me, I am a resident in ENT and head neck surgery. Also, I run a YouTube channel for NEET PG dedicatedly. As a hobby, I teach and I have authored several books. Now, I also come from a humble background, but what you can learn from me apart from these studies is how to overcome your struggles, because whatever I faced, I never stopped. What kept me going is my inner belief in myself. So same thing I expect from my students. So never ever give up in your journey. You will achieve whatever you are aiming for. Only thing is needed is the faith and believe in you. Okay, so right now Unacademy, they have great educators with them. So most of the famous teachers are now with them, and they have created a big platform, and the study materials will be going to help you a lot. They have some daily classes, live tests, structured course, and unlimited access to you. So they have also started with the same focus as I started my YouTube channel, to serve the community, to serve you all. Different subscriptions are there, and they have provided me with the code SHIVKES, which you can apply and get some discount. Now I think people have started coming, and we can start our presentation. Type I if you are here. Type I, and let me see how many of you are excited for the things that you are going to learn today. You can also type your queries while we go through the session, and I will address them at the end. Okay, okay, great. So starting this with a quote like, the trouble is you think you have enough time. Many students now ask me, sir, our exams are getting postponed. What we should do now? The thing is, the time will go off as never before. So whatever you are thinking, try to make it, convert it into your effort. The time will pass. The exam are going to happen either 10 days or 15 days, but they are going to happen. So if you have time, use them. Give your extra effort that is needed. To achieve something extra, you have to give something extra. So never ever stop and be hopeless or have fear in your mind, because like a butterfly, when a caterpillar thinks world is going to end, it was just the beginning. So something very great is waiting for you in your near future. So don't wait, give your efforts and achieve that. Okay. So our today's session will be based upon the NEET PG pattern questions, and why I am here to discuss those, because your AIMS exam is very near. Okay, your AIMS exam are near, and you need to know this question because they have overlapping things. So you have to go through the previous year question. It forms one of the major strategy for you to get through the exams. Straightway to the question number 1. Identify the lesion of vocal cord given below. Here what you can see is there is a vocal cord and some lesion, some mass is there at the laryngeal inlet, some papillomatous mass you can say. Options are Rinke's edema, laryngeal papilloma, malignancy, tracheomalacia. So what do you think it can be? Now showing you a similar question on the same topic. Why I choose this topic? Because it is being asked very frequently in your exams. Most common tumor of larynx in a child between 2 to 5 years. So it was asked in AIMS in some other year. Chordoma, juvenile laryngeal papilloma, infantile hemangioma, scleroma. So they want to ask you most common benign tumor of larynx. Great, many have given a good answer. Great, thumbs up to you all. You are really putting efforts. I am happy to see that. Now third question. Topical treatment for recurrent respiratory papillomatosis include. Options here are acyclovir, cidofovir, ranitidine, zinc. Why I discussed all the three questions simultaneously? Because all are interrelated, and for answering them you need to be thorough with one topic, that is recurrent respiratory papillomatosis. Now this is something which is very interesting for ENT people, and thus they ask this question repeatedly in your exam. So if you see this picture of laryngoscopy, here you can see a papillomatous lesion over the vocal cord. All of you can see that. So this is a peculiar lesion on the vocal cord, papillomatous, pedunculated many times. So basically we have to know about something called juvenile recurrent papillomatosis. So if we talk about this topic, it is the most common benign neoplasm of larynx in children. In children, most common benign neoplasm of larynx is juvenile recurrent respiratory papillomatosis, or you can say laryngeal papilloma. The etiology, if asked for the recurrent laryngeal papillomatosis, it is HPV 6 and 11. So this forms your future question. So this is a way how you can anticipate your future questions. They are focusing on this topic. While solving previous year questions, you will know the topics. Now know those topics in little detail. What you will see in recurrent respiratory papillomatosis is multiple sessile pedunculated fibril papillomas which bleeds on touch. The characteristic is mostly seen between 2 to 5 years, that is in infants and young children. Now similar to juvenile recurrent respiratory papillomatosis, there is another term called adult respiratory papillomatosis. What is the difference? What is the age limit that defines or differentiates juvenile from recurrent? It is 12 years. So it is given in the recent Scott Brown. 12 years is the age which differentiates a juvenile recurrent papillomatosis to adult onset recurrent papillomatosis. More commoner and more important for you is juvenile recurrent respiratory papillomatosis. Great. Most common site, by the picture you know it is vocal fold. Other sites, it can also occur in larynx, pharynx, trachea, and the presentation will be hoarseness. Anything which obscured the glottis, that is vocal cord, will cause hoarseness. And many a times these papilloma, they have a rapid growth and tendency to recur, and that is why they will cause closure of the laryngeal inlet. So once your laryngeal inlet, that is the airway, gets blocked with this papillomatous mass, your patient will present to you with a stridor. So they can form a clinical question next time in your near future in AIMS, that a child presented to emergency with stridor. On laryngoscopy, you found multiple papillomatous mass filling all the laryngeal inlet. What will be your next step? So in emergency, always go from ABC, airway, breathing, circulation. First comes is the airway. So at this time, you have to do tracheostomy. While for this recurrent respiratory papillomatosis, tracheostomy should be avoided because it has chances of local spread. The disease may spread to adjacent tissue, but when you have nothing in your hand, you have to save the life of that child, and then you will do tracheostomy. Now, what are the treatment modalities? The ideal treatment modality is microlaryngoscopy, CO2 laser excision, or we also can remove the papilloma and decrease the disease burden by microdebrider. What we have to keep in our mind is we need not to injure the vocal ligament, as it will cause a permanent scarring of the vocal cords. So as these are recurrent, they have tendency to recur, and most patients required repeated microdebrider excision of these papillomas. Some other supporting treatments are there, like interferon alpha and cidofovir. So that was asked. Cidofovir is basically a nucleoside analog and a broad spectrum activity against a variety of DNA viruses. So why it is important is it is available in a topical form. So you can use cidofovir in topical form for these papillomas. One more important point is that there are some HPV vaccines which are given as a prophylaxis for different genital diseases. So those nonavalent HPV vaccines are also useful to decrease the interval of the recurrence. Means they are prone to recur, but it will reduce the HPV prophylaxis will reduce the chances or the recurrence of these recurrent respiratory papillomatosis. So this is what you can say a recent advance or a added point you should know. So same thing, laryngeal papilloma, benign, most common lesion for the larynx. Now, inspiratory stridor is found in what kind of lesion? So very simple, only concept based question. So you will never get this ever in your MCQs books. These are the things which you get from your either ward clinics or from the practical experience while you see your patients in emergency and examine them. So basically they are saying when you get an inspiratory stridor, when you get a expiratory stridor, and when you get a biphasic stridor, that means the stridor is present in both the phases. Okay, a lot of people are studying, so great to see that. So inspiratory stridor, biphasic and expiratory. This figure will tell you everything. This is the level of glottis. So if I assume this as glottis, anything above is supraglottis, anything below is subglottis. So in supraglottic lesion, you will get an inspiratory stridor. In subglottic things belonging to thoracic, trachea, bronchi, means lower respiratory tract thing, if there is obstruction somewhere here, you will get a expiratory stridor. And if there is something impacted at the glottis, some obstruction at the level of vocal cords, glottis, then you will have that stridor in both the inspiration as well as expiration. So very easy. Moving to next question. A patient presented to you with a picture of tympanic membrane like this on otoscopy. Most probable diagnosis. So I think you can see here on otoscopy multiple perforations. What I can interpret from this image is a big central perforation here in pars tensa and some more like two small perforations in here in that pars tensa. So by now you all have been reading that multiple perforation are seen in tuberculosis. What they have added is they have given an otoscopic picture. So always try to correlate things while you study your notes or while you study from your MCQ books. When you correlate it with clinical things, you will be able to answer most of the questions. So this is the tactics that examiners are following now. So tubercular otitis media is the answer for this question. No, it's Amit. No, it's not AOM. Multiple perforations, particularly that are seen in here, are a feature of tubercular otitis media, and some more important features that are seen is they are painless. So most of the time patient have discharge but they don't complain of pain. So these differentiate the clinical scenario of a acute otitis media from tubercular otitis media. The hearing loss is disproportionate. That means they will have a more hearing loss, but the burden will be less. You won't appreciate that much that the patient can have this much of hearing loss seeing the otoscopy findings. It is painless and disproportionate symptoms. So anywhere you see this written in your question, disproportionate symptoms and the hearing loss, you can go for tuberculous otitis media, and they will also mention some added points like multiple perforation, painless things. Yeah, now you all are right. Tanasha, Amit Sinha, now you have right. Yes, very good. Tuberculous otitis media. So the above picture was tuberculous otitis media. Now this question is something which most people fear. Why? Because it belongs to a topic called vertigo. So most people at UG level are very fearful of this topic. The main thing in any topic, in any subject, is concept, and you need to build that. So gradually you will understand how things are now more conceptual based than your crammings from the notes and everywhere. So here you can see a maneuver being performed by a doctor from A to B to C to D and E, and it is wanting you to know which maneuver is this. Brands thereof maneuver, Epley's maneuver, Foster or Simont. Now to answer this, you should know which topic the examiner is focusing on. Yeah, you all have rightly said it's Epley's, but can you tell me, or if they have given a Simont maneuver or brand thereof maneuver, will you be able to answer it? Because it is Epley's and already have been asked, you have answered it. Yeah, so this is from a topic called BPPV, and this topic is important for you because it is the most common vestibular disorder, and in ENT one part of it is the vestibular disorder, the disbalance thing. Your patient comes to you with head rotating. So what you will do, most of the physician will refer to a ENT or to you. Then what you will do, so for getting that you should know what is BPPV, benign paroxysmal positional vertigo. Every word has a meaning, and that is why it is BPPV. Benign means it is not very serious, the progression is not very fast. Paroxysmal means it lasts for few seconds, less than minute. Positional is dependent upon position. That means the patient will give you a peculiar history of getting vertigo only on certain positions. So it is basically a disorder of vestibular, that is the inner ear system of your ear. So what happens? Basically what happens is the otoconial crystals, they get dislodged from the utegral and they slide into the semicircular canal. Most common is posterior semicircular canal. So it forms one of your MCQ, that is posterior semicircular canal is the most common place of dislodgement and getting BPPV. I will come to these maneuvers once you get a clear concept of what is BPPV, what are the future questions related to it, and the anticipated questions. Now, yeah. So can you tell me for what is Epley's? Epley's is basically a therapeutic maneuver. That means once you diagnose your patient with BPPV, you do Epley's to relieve him of the vertigo. And how you diagnose? Now for diagnosing, there is another maneuver called Dix-Hallpike maneuver. So for those who have attended their ward, they must have seen their residents doing Dix-Hallpike maneuver in vertigo clinic. So I will come to all of them. Basically, vestibular system, you all know, is made up of utricle, saccule, semicircular canals, some of the very basic thing, and it is caused by the microscopic calcium carbonate crystal called otoconia that dislodge and go into the semicircular canal. What main feature you will hear in the clinical finding of the patient is these are not associated with any hearing loss or any other symptoms except vertigo. That means you can exclude this vertigo from the complications of COM and from any other vertigo of central causes and other things, as these are not associated with hearing loss and any other symptom except the vertigo, which is very peculiar with the change of position and last for only few seconds, and you can say less than 1 minute. So vertigo is fatigable, and the nystagmus we get is also fatigable. Most common age of presentation is 5th decade, and generally the debris gets collected on the posterior semicircular canal, although it can also involve superior and horizontal semicircular canals. So management is by the vestibular exercises. First we try to do different maneuvers like Epley's, and then with medicines if we can get control of it. So the management includes a waiting period or pharmacotherapy with medicines, different maneuvers, vestibular rehabilitation, and finally if the patient is not responding to these treatment, we go for surgical things. But very rarely we require a surgical therapy for BPPV. And what MCQ you can be asked is, singular neurectomy is a procedure that is done for which condition, or for BPPV which of the following is an surgical option. So in that, singular neurectomy can be one of the option, and posterior canal occlusion can be another. What we all do in singular neurectomy, we section or we cut the posterior ampullary nerve that transmits information from the posterior semicircular canal to the brain. So a nerve enters into the posterior semicircular canal, and that nerve is posterior ampullary nerve. So this nerve is important, and it forms a part of inferior vestibular nerve. So once you cut this nerve, no more information is going into the brain regarding the sensation of vertigo, and thus patient gets relieved of BPPV. So it is a highly rational treatment but technically difficult. This figure that can be asked, shows you how a singular neurectomy is done. Basically via transcanal, means through the ear canal. What we do is we expose the round window membrane, and identify this posterior auricular nerve or singular nerve, and then cut this nerve with a pick. So main purpose is to disconnect this nerve to the brain and thus stop this vertigo sensation. Now coming to different maneuvers. So yeah, otoconia that is also a treatment, but these maneuver, most of the time with this maneuvers things get okay. So Dix-Hallpike is a diagnostic maneuver for posterior BPPV, posterior canal BPPV. Very useful, and what we do here is you can see here. So basically we have to hold the head of the patient 45 degree and have an eye contact with the patient, and then the angle is 45 degree tilted. Okay, then we lie the patient down with head overhanging and observe the patient for the nystagmus. Regarding nystagmus, there are different types of nystagmus with each semicircular canal that I will discuss. So basically, Epley's maneuver, after we diagnose BPPV by Dix-Hallpike maneuver or video nystagmography, which is a newer technique, very useful. Video nystagmography is also being done and being used widely for this. So Epley's repositioning maneuver is done to relieve the patient of vertigo. That means it is a therapeutic maneuver, and the principle is to reposition the dislodged otoconial debris from posterior semicircular canal back into the utricle. Concept is very simple, logic is very simple. So here you can see these Epley's maneuver, and yes, I don't know what name it is. Muster have said it involves 5 steps. Yes, you are right. So what we are doing here is, here the clinician is rotating the patient head towards the affected ear, and then we lower the patient backward to supine position with the head hanging over the edge of the table. Now each step we have to wait till the vertigo stops. That means till the nystagmus gets over. Then we turn the head to the opposite side, that means 90 degrees, so that the affected ear comes up, and then wait for 30 seconds. Then after this, the head is turned further so that ear is parallel to the floor, and we finally make the patient sit almost facing the floor like this, and slowly make the head up and observe the patient. So basically this all is done to reposition the otoconal debris that has been dislodged. So it involves 5 steps that you can read, and the thing is, you all know by now what is Epple's. Now coming to Simon's supine roll test and others. So this, if given in your exam, you have to answer it as Simon's maneuver. And what is being done? This patient, once she has been shifted with 45 degrees head to one side and then to another. All of them, the videos are available on YouTube, 1 or 2 minutes video. Go through them, differentiate them, but mostly they will give these images only. So this here, the simple procedure is Simon's maneuver. And when it is done, it is also done for posterior canal BPPV, used to overcome otoconial jam after Epple's. So after Epple's, you can do this Simon's maneuver. And this is supine roll test. Very easy. The patient is lying here, moves her head to one side and then on the other. So very easy to identify. The main aim of giving these images is you can identify these tests by their name. Because once they have given Epple's, in next time they will give Simon's, or next time they can give Dix-Hallpike maneuver or different things. Now what is this Brand's Derhoff exercise? So if with the Epple's the patient is not getting relieved, so you have to repeat 1 or 2 or 3 Epple's, then you prescribe him Brand Derhoff exercise. That means patient will go to his home and do these exercises to get relief. So used as a home program for posterior canal cupulolithiasis or persistent posterior canalithiasis. So basically purpose is same, but it is a home program, Brand Derhoff's exercise. It was one of the option which was there in the image. Now BPPV, this posterior canal is Dix-Hallpike is the diagnostic. For horizontal that we were reading, the supine roll test is for horizontal BPPV. So as for posterior, for the most common type of BPPV, we were doing Dix-Hallpike. If we have this horizontal BPPV, we will be doing supine roll test to see the nystagmus. For anterior also, we do the same, that is Dix-Hallpike maneuver. Now moving to a similar or a anticipated question on BPPV itself. Why I am focusing is this is important topic and difficult also, so you should know what can be asked from this topic. Yeah, so BPPV of posterior semicircular canal produces, can any one of you tell me the answer? Horizontal, pure vertical, pendular or torsional vertical nystagmus? Yes, if I can ask, who can tell me the answer for this? So basically the answer here is torsional vertical nystagmus. So what is the funda? What is the concept behind this? If your patient complains of torsional nystagmus with vertical or horizontal component, it means it has a peripheral cause of nystagmus. Why? Because if we see a BPPV of superior semicircular canal lesion, it will lead to torsional vertical downbeat nystagmus. If we have a horizontal semicircular canal lesion, it will lead to torsional horizontal nystagmus. So easy to remember, horizontal for horizontal, torsional is everywhere. BPPV of superior, so superior will be above, so vertical, torsional vertical downbeat nystagmus. And for BPPV of posterior semicircular canal, that is most common, we get both combined vertical upbeat and torsional nystagmus. So BPPV of posterior will give combined vertical upbeat and torsional nystagmus. So only vertical or horizontal nystagmus without torsion, or only torsional without vertical or horizontal, is seen in central causes of nystagmus. That means without torsion or only torsion without vertical or nystagmus is seen in central cause of nystagmus, while for peripheral cause there must be a torsional component or combined form. So this was an anticipated question that can be asked to you. Moving to our next question, can you identify this image, this otoscopic image? So now they are so much focused over clinical pictures. They want you to see the image of the ear with every disease when you are attending your wards. So whether it is an acquired cholesteatoma or keratosis obturans. So I have been allotted less time this time for only half an hour, so I'll be little faster. So whether it is acquired cholesteatoma or keratosis obturans, the two main differentiating or the confusing points are between acquired cholesteatoma and keratosis obturans. Yes, this otoscopic figure. So if you see this, keratosis obturans is basically accumulation of desquamated epithelium in the external auditory meatus, while primary canal cholesteatoma is invasion of squamous epithelium or tissue into the ear, into the bony canal. So both have a different physiology, but how you will differentiate them? This figure here shows you a neglected keratosis obturans, and here you can see cholesteatoma of external ear canal. So both have different physiology, different pathophysiology involved. How you will get that? By the symptoms and the pathology. In keratin plug, you will have the conductive hearing loss and whole of the keratin debris filling the external auditory canal, while in primary auditory cholesteatoma it will be keratin deposition in random fashion. Here whole of the canal is grossly widened in case of keratosis obturans due to the pressure of the desquamated debris being collected. The canal becomes equally or widened equally all around and grossly widened, while in this case it is localized osteitis or erosion of canal, usually at some particular site, not whole of the EAC. This keratosis comes with severe otalgia, younger age, and occasionally, or you can say mostly, they have some syndromic or more than one disease association. That means they will be associated with some lung or sinus disease. They can be associated with different desquamation diseases where the skin has tendency to desquamate, and that is why they are mostly bilateral, while the primary auditory cholesteatoma will be unilateral thing. So there are a lot of features that will differentiate it, the keratosis obturans to the primary auditory canal cholesteatoma, starting from the clinical history to the examination to everything. Now something about keratosis obturans that you should know is it is collection of purely white desquamated epithelial cells in the deep meatus, that means in the external auditory canal, in the deep part of the meatus, and it is the pathology is due to defective migration of the epithelium from the surface of tympanic membrane to the posterior meatal wall. So the reversal means the reversal of epithelial migration occurs here, and due to this failure of migration there is collection of epithelial debris, the desquamated epithelium, that leads to conductive hearing loss. So it is something which will have a conductive hearing loss in the auditory, or as such one of the complaint of the patient. Now another topic which was asked was regarding brachial cyst, most common site of brachial cyst. So for getting this answer right, you should know that what are these and what are the anticipated question as for any other question. So anterior border of the sternocleidomastoid, and mostly the second question that can be asked is second decade of life and associated with second brachial arch anomaly. So they are mostly a second brachial arch anomaly thing located on the anterior border of the sternocleidomastoid. So I would have shown you a picture where there was a swelling on the lateral part of the neck in the anterior border of the sternocleidomastoid, mostly a congenital thing but detected in second decade of life after it become infected or enlarges. So you will get a picture of a child showing a mass on the lateral aspect of the neck, unilateral mass. So most probably these are brachial cysts and caused due to anomaly of second brachial arch. So second brachial arch is something important that you have to remember for your future examination. The treatment is very simple. You have to excise this cyst, and the operation is called step ladder operation. That means we have to trace this cyst tract. So sometimes, many a time, the tract open at the base of tonsillar fossa. So we have to remove this cyst in a step ladder pattern. That means multiple incisions are given. With one incision, we get through a particular amount of tract, and then to access more above we give second incision. So that is why it is called step ladder approach for excision of brachial cyst or sinus. Now this is the final image. I think I have exceeded my slot of 30 minutes, but still you can have this also. A child with history of severe pain in throat with hoarseness of voice with high grade fever and toxic look. What clinical condition the image is depicting. So everything is clinical now. Identify the lesion. Membranous tonsillitis, follicular tonsillitis, diphtheria, aphthous ulcer. So they are focusing on the emergency case that you get while you do your internship. So do focus on the emergency cases on every subject you are reading, because these are now being focused as your NEET has also become clinical approached, and they have started asking these clinical scenarios more than the previous one-liners. The answer here is diphtheria. Some important lines you all know about this is diphtheria caused by Corynebacterium diphtheriae usually start 2 to 5 days after the exposure, and the peculiar thing about its membrane is these membranes are quite tenacious and cause bleeding when we try to remove it. So highly infectious disease, it forms a membrane over the tonsil and the patient have a high degree of fever, fatigue, headache, coughs, difficulty in swallowing, painful swallowing, difficulty breathing. So a lot of emergency things that are there with the diphtheria. So I think I'll conclude this session and with a message that solving previous year questions are important and you should go through them once before your any exam, and I think you will make it. Only thing is you have to keep on giving your effort. Efforts are the thing, actions are the thing that will matter in the end. So don't ever waste your energy in procrastinating thing. Only thinking about something doesn't make it possible for you. You have to make things possible for you. So with this message, I am ending this session. Do tell me how this session was and how much you liked it, how much it helped you to get the concept and an understanding of in what way you should go through it. This is Dr. Shivam signing off. Thank you all. Thank you all for being here and for your active participation. Thank you. Stay healthy, stay safe. I'm ending this. All the very best.